Hello everyone, you're tuned into today's PIR live event and I'm your host Scott Jones. Today is World Health Day 2016 and the World Health Organization has designated today's focus as Beat Diabetes. To help us learn what is being done already and what each of us can do, we're joined by Dr. Jan Hux, the Chief Science Officer at the Canadian Diabetes Association. Welcome and thank you so much for joining us today, Jan.
Thanks, Scott, and hello, everybody. It's a pleasure to be able to celebrate World Health Day with you. I'm going to spend a few minutes talking to you about what is diabetes and then talk about some recent research advances in the area of diabetes. And then I'll certainly try and leave lots of time for questions at the end. So I'm just going to get my slides up here.
Okay, while you're doing that, I'll just welcome everyone that's watching today and remind everyone that you can tweet your questions using the hashtag AskPIR anytime during our event, and then I'll relay them to our guest during the question and answer period. If you can, please include your name, school, or city, and we'll give you a shout out. So I look forward to getting to those questions, but I'll turn it over now to you, Dr. Hux, to go through your presentation.
And Scott, can I just confirm that you can see my slides?
Yes, I can, yeah.
Okay, great. So really, diabetes is a disease where glucose can't do its work because it gets trapped in the bloodstream. So this slide really shows how glucose works. Glucose is a type of sugar, and a lot of the foods that we eat ultimately just get broken down into glucose. So it's just a fancy word for talking about the fuel that is in the food we eat. So your food runs on energy, your body runs on the energy it gets out of the food that you eat. That gets turned into glucose, or a type of sugar, which gets absorbed into the bloodstream. When the sugar is in the bloodstream, the pancreas, which is an organ that sits right behind your stomach, recognizes the sugar is there and sends out insulin. Insulin is like a key. It lets the sugar into cells, and so the insulin allows the sugar to go into the cells where it can energize muscles and other parts of the body that need energy to work. That's how it's supposed to work. You could think of it being like a car. You put fuel or gas into the gas tank. The fuel pump sends it around, and it needs to actually go through the injectors and be put into the engine. And there's a blockage right here. So just as when your fuel injection system is blocked, your car doesn't work very well. When your glucose injection mechanism doesn't work, then your cells don't work very well. There are two main types of diabetes, and they have different problems with the glucose injection system. The first type I'll tell you about is type 1 diabetes. And it wouldn't surprise me, actually, if somebody on this call actually has type 1 diabetes, because type 1 often begins in childhood. In type 1 diabetes, the cells that make insulin had been wiped out. Your own immune system went rogue and it attacked the cells in the pancreas that make insulin. So because the body isn't able to make insulin anymore, there's no way to get the fuel into the cells. And people who have type 1 need to take insulin injections, often 4 or more injections a day, to keep their insulin levels at the right level so that the sugar can constantly be moved in to feed the cells. The other main type of diabetes is type 2 diabetes. And in type 2 diabetes, your body is still making insulin, but it's stopped working. It's as though the key that allows the sugar to go into the cells is still there, but somebody changed the lock. And now that key can't work, so the sugar gets trapped in the bloodstream. And in the same way, the cells don't have the energy they need to do work. That's sort of a scientific explanation. What does that mean for a person who has diabetes? And I don't seem to be able to advance my slides. There we go. I apologize for that delay.
No problem.
So I think about managing, keeping the blood sugar levels at a healthy range, being like a three-legged stool. There's a food leg, a medication leg, and an exercise leg. Whenever we take in food, it increases blood sugar levels, while exercise and medicines lower the blood sugar levels. So the three have to constantly be kept in balance. If you eat a little extra food at lunch, you may need more medicine or more exercise to get those blood sugar levels down. If you spontaneously get invited to play a game of pickup soccer and exercise more than you intended, your sugar levels may go dangerously low if you don't eat extra food or cut back on the medicine. It's a constant balancing act. That means that diabetes is a big challenge for people who are affected by it. It's a big challenge really every day. Everything needs to be planned. It's actually hard to have that spontaneous soccer game. It's hard to skip lunch if the food in the cafeteria looks gross on any particular day. Everything has to be planned and done according to schedule, and there needs to be regular testing. Someone who has type 1 diabetes may need to test their blood sugar 8 or even 10 times a day, stabbing their finger, taking a blood sample, and testing it to see what the blood sugar level is. And I think another thing that makes diabetes challenging for people who live with it is that often they're misunderstood. Other people give them bad advice. They would say, oh, well, you have diabetes. You can't have that piece of birthday cake. Giving wrong information that makes someone with diabetes feel misunderstood and feel like they don't really belong. But diabetes isn't just a big challenge today. It's really a big challenge for the future as well, because we know that people who have diabetes are more likely to get heart disease, kidney disease. They're more likely to go blind or even have a leg amputated. And those things are especially more likely if the diabetes is not well cared for. That's the challenge at an individual level, but diabetes is also a big challenge for us as a country. 3.5 million Canadians have been diagnosed with diabetes, and another 1.5 million have diabetes but haven't yet been diagnosed. And then on top of that, 6 million have pre-diabetes, which is abnormal blood sugar but not bad enough to be called diabetes. That's a total of 11 million people. We estimate that by 2025, just like in this picture, 1 in 3 Canadians will either have diabetes or pre-diabetes. That is a huge impact on the healthcare system. And that problem is worldwide. If any of you were watching the news last night, you may have seen a report coming out from the World Health Organization that says there are now 422 million people around the world who've been diagnosed with diabetes. So it's a huge challenge. And what can be done about it? Well, that's the kind of challenge researchers like to take on. So I'm going to tell you a bit about some research that's being done to help cure type 1 diabetes. Remember that I told you in type 1 diabetes, the cells that make insulin have been destroyed, so you don't have any ability to make insulin. Well, you might ask the question, why can't we just replace them? Why can't we transplant cells in? That's what some researchers in Edmonton are asking. I don't know if there are any Edmonton schools online, but you can feel proud of yourself because the Edmonton protocol is recognized worldwide. This work began about 20 years ago, and what they did was take islet cells, those are the cells that produce insulin, from an organ donor pancreas. They don't need to transplant the whole pancreas. They actually just take those cells, they inject them into a vein that goes into the liver, and the cells can actually find a home there in the liver. They don't need to take up new space. So it sounds perfect. Except, remember why you ran out of islet cells in the first place? It was because your immune system was attacking them. And sadly, the immune system attacks those new islet cells that have just been transplanted. So people who are getting these transplants need to take really strong anti-rejection drugs so that that original problem doesn't start all over again. Now, how can we fix the two problems? We certainly need more islet cells. There aren't enough organ donors. And we know that stem cell technology can be used to create whole clones of cells. So scientists are working to create clones of cells that they can then program so that they're sure that those cells will grow up to become islet cells. And that's a really interesting field of research. But if you put those in, you're going to have the same problem of them being attacked by the immune system. So you need to find a way to protect them without shutting down the immune system. We need our immune system. So we need to protect them, but they still need to be able to communicate. So we can't put them in a plastic bag because then they couldn't communicate. But wait a second, a tea bag. What about a tea bag? That might work because the cells can be inside the tea bag. The sugar can go in, signal the cells to make insulin. The insulin can get out, but the tea bag is strong enough to protect those cells from the immune system attack. And so that's exactly the research that's being done in both California and Edmonton right now. They've cloned cells that are programmed to become islet cells. They put them into what's called a semi-permeable membrane that lets the sugar in and lets the insulin out, but it prevents the immune system attack. And the first Canadian patients have just been enrolled in the last year. So stay tuned. If this is successful, it would free people with type 1 diabetes from having to do testing and having to inject insulin. And I think I'll just talk very briefly about type 2 diabetes. We're more interested in preventing type 2 diabetes, and we think we're a much longer way from a cure. To prevent type 2 diabetes, we need to think about what causes it. There are causes in our genes, in our lifestyle, and in our environment. We know that type 2 diabetes really runs in families, and we can't change our genes. So I think it's important to know what our risk is, but then the things that can be changed are our behavior and our environment. By behavior, I mean individually making good choices and helping others to do the same. And in terms of our environment, advocating for change in the environment around us that actually contributes to causing us to get diabetes. Let me give you some examples. In terms of changing our behavior, we need to have a more active lifestyle. It's ironic that all of us are sitting in front of computers and I'm telling you to be more active, but less screen time and more outdoor unstructured time is really important to be preventing diabetes. And also a healthier diet. We recommend that if you look at your plate, that half of it should be vegetables, especially green and orange vegetables. And we're really recommending that you limit or eliminate sugary drinks because they seem to have a direct impact on diabetes. In terms of change in the environment, we're looking for things like improved labeling on foods, restrictions on advertising, maybe even a tax on sugary drinks, just to remind people that those aren't the healthiest choices. And if people aren't supposed to be drinking sugary drinks, making sure that they have free access to water. And then finally, raising awareness and communicating with others and getting others on board with spreading the news about how the impact of diabetes can be reduced. So I'll call it at that and be happy to take questions.
Great, thank you very much, Jan. So I have a few questions, both from a secondary school in Mississauga and then another school in Toronto. I'll follow up first on the question from the secondary school in Mississauga, and this goes on to ask about the stuff that you're talking about in terms of the islet cells and the encapsulation clinical trials that are happening now in Canada. The question is, how long does it usually take for a technology like this to go through clinical trials and become available to the public?
That's a really interesting question. At the Diabetes Association, we often tell the story of Drs. Banting and Best discovering insulin, and from the time that Dr. Banting came up with the idea until the first patients were treated, it was about 4 months. Nowadays, things are much more rigorously tested and evaluated and regulated before they can get into real practice. And so that's safer for people, but it's sure frustrating for those of us who are waiting for the results of these studies. The first patients were enrolled in this trial about, it'd be close to 2 years ago now in California, and they want to assess all of the patients for a full 2-year period. So I think from this first trial, it'll be probably another 1.5 years before we get the results. And then the government is going to figure out how this needs to be regulated. It's a lot harder to test a batch of stem cells that are destined to grow up to be islet cells than it is to test that an aspirin is an aspirin is an aspirin. And so the regulatory pieces, while it's frustrating that we have to wait, it's important for the safety of patients.
Great. Okay, so now I've got a few questions from grade 5 and 6s at Regal Road junior public school in Toronto, and they seem to be along the lines of dealing with symptoms a bit more. Um, so Eric wants to know, what happens to your body when you fall into a diabetic coma?
Great question, Eric. So a diabetic coma happens when your blood sugar either is extremely high or extremely low. When it's extremely low, often people would call it an insulin reaction. So I talked about sugar being the fuel for your cells, and if you don't have the right amount of insulin, the fuel can't get into the cells, or if you have too much insulin, there's no fuel to get to the cells because it's all moved in. When insulin levels are too high, the level of sugar in the blood goes down, and the brain is one tissue that just needs a constant supply. You can't really store it up. It needs to be constantly being fed. So if the level of sugar in your blood gets too low, then the brain just can't function properly. And so the first thing that a person might notice is they would feel a little confused, they might feel sweaty, they might actually have some hunger. But if that progresses, if the blood sugar remains low or goes lower, they may actually become unconscious, they can have a seizure, and in the worst case scenario, people can even die from an acute low blood sugar. At the other extreme, you would think, well, okay, I'm going to be safe and I'm going to keep my blood sugars high. That's dangerous too. High blood sugars over the long term really increase the risk of complications. But if the blood sugar becomes too high in a short period of time, that also can make someone extremely sick, and they can fall into a state where their blood becomes very acidic and none of the organs work well.
Mm-hmm, mm-hmm.
So that's why it's so challenging. You can't, managing diabetes is a 24/7 job. You can't take a vacation from your diabetes. It's always there, and it always needs to be managed carefully.
Okay. So a follow-up question to that from Luca. What should you do to somebody if they happen to find themselves in diabetic shock?
So if somebody has been, fine, and over the space of a few minutes becomes confused and seems to be more incapable of caring for themselves, getting some sugar into them is always safe. The most dangerous thing at that point is that that the sugar continues to go low. I think the first thing is to call for help. In a school setting, get a teacher involved, get somebody to call 911, call their parents. And if they're awake, try and get some sugar into them, some juice or pop, or if they carry glucose tablets, those are great. But if they're really starting to look quite groggy, trying to put something in their mouth can actually be dangerous. So getting help is always the first step. And then if the person is alert enough that they can swallow some juice, that's also good. And you may think, well, I'm not sure whether it's too high or too low. If it's too high, swallowing a little sugar isn't going to make that much difference, but it can be life-saving in somebody whose sugar is too low.
Mm-hmm, mm-hmm. Okay, I know you talked about it a little bit, but Zane wants to know, what are the differences, aside from how you actually contracted the diabetes, between type 1 and type 2?
That's a great question, Zane. In some ways, they seem identical. We make exactly the same test to diagnose them. They're diagnosed on the basis of a fasting blood sugar that's above 7, or there are other tests that measure your average blood sugar. And so are they the same thing? No. People with type 1 actually have more trouble keeping that blood sugar in that narrow range, I think, for a couple of reasons. One is that their bodies are very sensitive to insulin. They don't have that insulin resistance that I talked about. So even a little extra insulin will really push their blood sugar down, whereas somebody with type 2 diabetes has insulin resistance, and a little more insulin is not going to have that same effect on them. The other reason is generally type 2 onsets later in life, and so you don't have as many years to really build up those adverse effects. But somebody who got diabetes when they were 7 years old and who wants to be healthy at 77 has a lot of years to take care of their diabetes, and so that's more challenging. The complications that they get are pretty similar. Both groups are prone to vision loss, kidney damage, damage to the nerves that carry pain messages from the feet that ironically can actually lead to an amputation. They're prone to heart disease and stroke. So those long-term complications are the same between the two. It's really how challenging it is to manage it and what medications we use to manage it. People with type 1 all need insulin injections. you may ask, well, why can't you just swallow the insulin? Unfortunately, the acid in the stomach breaks down insulin, so the only way we can get it is through injection. There have been some studies of actually nasal insulin where you would spray it into the nose and it would get absorbed without being exposed to the stomach acid. And for some people who really have problems with needles, that's helpful. Many people, young people, are now taking advantage of having an insulin pump that delivers insulin continuously. For people with type 2, often for the first few years of their illness, they're able to get by without any insulin just by modifying their diet, improving their exercise, and sometimes taking pills once or twice a day.
Okay. So again, this comes from Aiden, but do you have to? Is it always just a matter of doing the best you can to treat the extremes of the disease, or like is there a diet, say, that eating the correct foods you can maintain an equilibrium as far as your blood sugar levels are concerned, or are you always going to be fluctuating back and forth no matter what you do?
So I'll talk about that in type 1 and type 2. So in type 2, which is much more related to diet and obesity, the diet is so important. I've seen patients who were requiring insulin, who got serious about their health, lost 50 or 60 pounds, and were able to be on no medications. They really were freed up from the burden of managing their diabetes just through weight loss. And so the diet piece is so critical there in terms of a way to manage the disease. In contrast, in type 1, no amount of good diet is going to get you off the needle. That's going to always be essential. I do think that working with a healthcare team, particularly talking to a dietitian and making sure that you go over your blood sugar levels with your nurse educator or your doctor to really find the pattern of insulin injection that works best for you is so important. But one thing I will say is that I have seen patients, it's not the majority, but some who, despite doing all the right things, still have trouble controlling their blood sugar. We talk about them having brittle diabetes, and that just a little too much insulin and their sugar crashes, and just a little too little, and they're suddenly up at 20. And they're told if they do a good job and if they follow all the instructions, they'll be okay. And that's a little unfair because some people just seem to have problems. I think I would challenge any of my patients with diabetes to work with the healthcare team to come up with the best plan and follow it as well as they can, but also to be gentle with yourself. You're never going to be perfect. This is an imperfect science, and really just trying to do the best you can.
Mm-hmm, mm-hmm. Okay. So again, these questions are coming from grade 5, the grade 5-6 class at Regal Road Junior Public School in Toronto. And this one comes from Ethan. Ethan has heard that diabetes has quadrupled since 1980. What is your opinion of the cause of this?
Ethan, you were watching the news last night and you heard the World Health Organization report. You're exactly right. It's quadrupled since 1980, and that's very alarming. A lot of that growth, and in fact the most rapid growth, is happening in developing countries in East Asia, Southeast Asia, and South Asia, so the Indian subcontinent, China, and Southeast Asia. In those countries, we know that there is a genetic risk for type 2 diabetes. But for many years, we still didn't see high rates of diabetes because those countries were in such difficult economic circumstances that not many people could afford to eat enough to become overweight and get diabetes. And that's one of the ironies of diabetes epidemiology. In Canada, we see diabetes clustered in the low-income communities. In developing countries, it's often clustered in the most affluent because they're the only people who can afford enough calories to become obese, and then their diabetes manifests itself. And so I think one of the drivers of this epidemic that we're seeing and that the World Health Organization reported on is that those economies are emerging. We have more people who are somewhat more affluent, and because they're able to eat more food, obesity is following, and then they're developing diabetes. And so the World Health Organization, as Scott mentioned, was calling on countries to take action to stop diabetes, to beat diabetes on World Health Day. And they're talking about programs that really promote the consumption of healthy foods, right from breastfeeding through to healthy fruit and vegetable consumption, and encouraging people to stop getting their calories through empty sources like sugary drinks.
Okay, okay. Um, so I've got a question here on Twitter. I don't have the school, unfortunately, but it's a good question, I think. So the research efforts that are ongoing, that are occurring right now as we speak, are there any? So we know there's some geared towards managing diabetes, but are there any that are working towards negating the diabetes gene, like the genetics aspect of it?
There's certainly, I would say that none of those that I'm aware of are close to being tested in humans, but in terms of negating the onset of type 1 diabetes, there's a very interesting, and we're going back to Alberta, a very interesting piece of research happening in Calgary, where Dr. Per Santa Maria is interested in understanding what's going on when your own immune system attacks your islet cells. And so he created a small, he calls it a nanoparticle, that has the same surface marker as the islet cells, in hoping to lure the immune attack away from the islet cells. And what he found was, when he gave that nanoparticle, not only did it lure the immune system away from the islet cells, it actually induced some protector cells to come in. So he describes it as turning terrorists into peacekeepers, that your immune system was terrorizing your pancreas, and now peacekeepers have come in to protect it. And he's been able to show that he can stop, in mice, that he can stop that immune attack. So someone who's just been diagnosed with type 1 diabetes, if he can stop the attack, they can keep their own islet cells, and that's the best case scenario. They don't need any additional treatment if they can keep their own islet cells. And so that is on the brink of going into clinical trials. Now, sadly, for those who already have well-established type 1 diabetes and don't have any beta cells left, that's not going to help them. But even for people who get transplants, there may be some science that grows out of that will help people better maintain transplanted islet cells as well.
Mm-hmm. Um, so I guess overall, then, given all of this research that's occurring, in your opinion, what are you most excited about in terms of developments in recent years? Where do you think the most progress has been made, and where is there the most hope going forward?
I'm certainly very hopeful, and in type 1, I think that these islet cells in a tea bag, the encapsulated islet cells, offer tremendous hope. I'm confident that within my lifetime we'll have something that really functions as a cure. Even if your body still has a tendency to make those antibodies that attack islet cells, if we can safely implant them in your body in a way that they're protected and you are freed up from injecting and from testing, I think most people with type 1 diabetes would declare that the war had been won.
Okay.
But I'm also encouraged on the type 2 diabetes front in terms of our better understanding of the environmental impacts. And so we talk about behavior, but I think it's important to, again, understand how our environment influences our behavior. We talk about some people living in food swamps. If you walk outside your front door of your condo building and the first 7 doorsteps you pass are greasy fast food outlets, your chances of having a healthy diet are less. Some people live in food deserts. They live in an area where it's miles or kilometers to anything where you can get food that isn't a mini mart or a fast food restaurant. So it's very difficult for them to get the fresh fruit and vegetables that they're required to eat. And so I think that what's encouraging to me is that gets us away from blaming the individual for making bad choices and really putting an onus on governments to make better policies to ensure that the best options, the healthiest options, are easier for people to achieve.
Mm-hmm. Okay. So I guess I'll leave you with one more question before we run out of time here, and that's maybe advice for our students in terms of what to look for on a food label. How to make the best diet and exercise choices in order to prevent these type 2 diabetes. Any take-home messages for our students then?
Sure. So we're concerned about free sugar that's delivered in a beverage. And so let me back off from that. I mentioned that in type 2 diabetes, obesity is a major risk factor. It doesn't matter what made you obese, whether it's too much protein, too much sugary drink, or just a little too much of everything. If you're obese, your risk for type 2 diabetes has gone up. And so I think, what do we need to watch for? We need to watch the scales. We need to, in the sense of we need to really be careful not to get on that pathway of being overweight and moving toward obesity, and managing that both through being more active and eating more healthily. On top of that, recent research has shown that there's an added impact of sugary drinks. So if you had two people of the same weight, even a healthy weight, and one of them got a substantial proportion of her calories from sugary drinks, and by a substantial proportion I mean 1 or 2 servings a day, her risk of diabetes is 25% higher, even if she's at a healthy weight to start. And so eliminating sugary drinks from your diet is a really healthy step that everyone can take. And those of you who have pop machines and sugary beverage machines in your school, you can start advocating. You can help not only yourself but your fellow schoolmates by advocating to get those machines out of the school.
Okay, great. So I certainly enjoyed that today. Unfortunately, we're fresh out of time. So I'd like to say thank you again to everyone on the live stream who was with us today. And of course to you, Dr. Jan Hux from the Canadian Diabetes Association, for taking the time to share your expertise and answer our questions today. Thank you so much.
Thank you.
All right, I'll just do a quick plug for our event next week, when we'll be talking about the food crisis and what we can do to make sure there's enough food for our growing population in the face of climate change. So join us on Tuesday, April 12th, and we'll get the answers to those questions from Dr. Evan Fraser from the University of Guelph. Look forward to that, but in the meantime, thank you again, Dr. Hux.
Thank you.
All right, bye for now, everyone.